What I want you to get from this PowerPoint and this lecture, there are certain code sets used for specific healthcare settings. I want to review the importance of correct code assignment for diagnosis, procedure, and POA indicators, because those three things then drive the MSDRG assignment. I also want you to understand the importance of correct diagnosis coding of a major complication comorbidity or a complication comorbidity, because those additions can infect reimbursement. And there are symbols in your ICD-10-CM codebook that tell the coder if a specific diagnosis is a CC or an MCC. Understand the importance of the correct assignment of the POA indicator, and last of all, understand how the MSDRG system drives. Providers and payers use ICD-10-CM for diagnosis reporting, all healthcare settings. Procedure reporting, it varies on the setting. For hospital inpatient, ICD-10 PCS is the standard, and for hospital outpatient, any ambulatory centers, surgery centers, physicians, or non-hospital providers, CPT and HIT are going to be those two things that you are doing for procedures or for supplies. HIT are mostly supplies. Here's a table, gives you in detail how each one is set up. Today I'm going to be focusing on the prospective payment system for hospital acute inpatient, but as you can see, each type of setting has its own classification. But in each one of these settings, the diagnosis reporting is what drives the payment. Under the inpatient prospective payment system, each inpatient admission is categorized into a diagnosis-related group, or DRG. DRGs are now called MSDRGs, Medicare Severity DRGs. It's the same definition, just a different name. The payment weight is assigned based on average resources used to treat a Medicare patient. Each inpatient admission is grouped into one DRG. In the outpatient environment, you can have more than one APC per encounter, but for the inpatient, one DRG. The principal diagnosis, along with the presence or absence of a complication or comorbidity, may affect the DRG classification, and secondary diagnoses can also affect the classification if they are an MCC or a CC. That's why it's important when you're looking in your code book and you have those little symbols over on the right for the CC or MCC, that you can tell if you capture something that the patient has that's going to affect the DRG. You want to be sure and do that. More on DRGs. When the DRG system was introduced, hospitals began looking not only at the number of services provided or the days of care, but the case mix or the type of care. And that was going to be classified based upon how many of the hospital's resources were used to care for that patient. So by definition, a case mix is a set of categories of patients, both type and volume, that's treated by an organization and represents the complexity of the organization's caseload. For example, when I was a case manager, we would have our morning meeting. We would begin by saying the volume, what number of each type of patient that uses a lot of resources did we have. We would classify by spinal cord injury, brain injury, ventilator dependent were our three big ones, and then as we got into more stroke rehab, we would talk about stroke rehab. And we would talk about the number of each one of those, because that is going to really pay for many things in our hospital, especially the admissions that are there for only a couple of days that don't have a lot of money attached to them. Yes, you need that to be captured accurately, but these high dollar cases you really need to be capturing accurately because there's so much more money. So a high case mix, the reason why I bring this up and for you to understand it is that these high case mixes represent the high complexity of those patients. They typically have longer lengths of stay, they consume more resources, they have larger medical records and take longer to code. But they are going to often get pushed to the top of the coding queue and be coded during the patient's stay and not held until discharge because of the amount of dollars that the hospital can recoup from this type of patient. Prospective payment system, each hospital's prospective payment system is a PPS rate, is a dollar amount based on that hospital's cost of operating. There are so many factors. I looked at some of these formulas online, and they're available if you want to look at them, but it's so complicated. Really, the only thing you need to know is that each hospital has been assigned a PPS rate based on a lot of factors. So you're going to multiply whatever that rate is by the DRG's relative weight, and that's going to tell you what the hospital is going to be paid for that admission. And remember, you can only have one DRG per admission. That DRG relative weight is assigned and published in the Federal Register, and it's a multiplier that's used to determine our reimbursement. So just to remind you, the case mix value or the relative weight is assigned to each DRG, and there are, in fiscal year 2015, there were 753 DRGs. I couldn't put my hand on 2016 table, but what it tells you is each DRG weight represents the average resources required to care for cases in that particular DRG relative to the average resources to treat cases in all DRGs. The hospital is going to have a PPS rate. That's a constant that doesn't change. Your DRG value is going to change because it's going to be driven by the diagnoses that you've assigned to that patient. Also, the value of your DRG is going to depend on many things, one of which is location. For example, a hospital in rural North Carolina would have a different PPS rate than a hospital in Metro Denver for the same DRG. Here's an example where we bring all this together. Patient A is a 16-year-old admitted for surgery to repair an umbilical hernia with no obstruction or gangrene. She has no contributing MCC or CC conditions. This is very straightforward. The appropriate diagnosis for her is going to be K42.9. Your coding software is going to take that K42.9, and from it is going to go into the selection of your DRG assignment, which is called a grouper. Your DRG that's going to be picked up is going to be DRG number 144, and that DRG is for hernia procedures age 0 to 17, and it has a relative weight of 0.9098. Remember, the hospital's PPS rate is a constant, no matter what the DRG is. So in our example here, the hospital's PPS rate is $4,000 for a 1.0 value of service. So to calculate the hospital's reimbursement, you're going to multiply the DRG's relative weight, 0.9098, times the hospital's PPS rate, which is $4,000, and that's going to give you $3,639.20. That is what the hospital is going to receive as payment for the entire hospital stay for this young woman coming in for hernia repair. Note in our math there, the DRG value is a direct multiplier, so it's very important that that number is correct when you start crunching the numbers. Now let's talk about present on admission indicators and how they fit in to reimbursement. By definition, a POA indicates a condition that is present at the time the order for inpatient admission occurs. Any conditions that would develop during an outpatient encounter, including the emergency department, observation, or outpatient surgery, are considered present on admission when the patient comes into the hospital as an inpatient. So the key time frame in this definition is at the time the order for inpatient admission occurs. Why is this important? Because if a condition develops during hospitalization, it's now called a hospital-acquired condition, or a HAC, or an HAC. Reimbursement is going to be affected by that. If a condition occurred prior to inpatient admission, it would be considered to be present on admission, including adverse effects. I wanted to be sure that I put that in there, because if a patient is having a reaction to a medication that's been appropriately prescribed and taken, that is considered present on admission. The hospital is not going to be penalized for that. When you're assigning your POA indicators, it is dependent upon the physician's documentation. You cannot accept nurses or any other allied health professionals' documentation when determining whether or not a POA indicator exists. A select number of hospital-acquired conditions are not recognized by Medicare so that you could put them into this higher severity DRG. So that's why the existence of a HAC can affect reimbursement. One example that's given here, if the only CC or MCC reported on this patient's case is one of those HACs, the case is not going to be assigned to a higher weighted DRG. In conclusion, coders have a legal and a fiscal responsibility to the facility and to physicians to code accurately. Becoming a professional coder requires lifelong learning, not only to stay on top of medical developments, or as well as any changes to coding guidelines, but changes to our federal laws as well, or federal regulations for how we would code something. It is really a great profession for someone who wants to be a lifelong learner. If you have any questions, please post them in discussion board or contact me, and I hope you have a good day. Thanks.